Well, thank you for joining today's webinar titled, Are You Ready? Readmission Penalties Are Here to Stay. So we get started, just one quick housekeeping item. If you have questions, please type them in the Q&A box located at the bottom of your screen. We'll make sure to save some time at the end to address these. And now I'll turn it over to Jvion's Chief Medical Officer, John Frownfelter.
Thank you, Jay, and thank you everyone for your time today. In presentation mode, so I won't see discussion questions until the end. Jay may interrupt with something though if it's particularly relevant right then. And we're going to jump right into the presentation here. I want to highlight first what Jvion does as a quick overview is we not only identify patients who are at risk because predictive analytic models generally do that pretty well, but with machine learning, we also identify why patients are at risk. And that's the assessment portion there. And then also which interventions are going to be most impactful for each individual patient. So the net of it is that these are insights that fit into the category of prescriptive analytics. Now, this is important because it allows us not only to see the unseen patients and to do things that otherwise wouldn't be done on those patients, but this is an enabler for moving into a fee-for-value world. Moving into fee for value, and we're all either already there or engaged in the process to moving to value, means managing risk, and identifying and managing risk is different than just managing patients the way we've always done it. Having good processes won't be enough, and as health systems, as providers, as healthcare around the country is graded on the curve, value is defined by if we're better than somebody else. So these differentiators of having better insights and acting on them efficiently is going to become more and more important. This is one of the studies that we're going to review, but I want to start with the takeaways for this reason. When we look at the takeaways, are you able to say this today about the solutions that you're using to manage your patients and prevent readmissions? First, are you able to accurately identify the patients that are at risk? Secondly, are you finding that the insights and the analytic support that you have helps you to better coordinate the services, both within the hospital and then post-discharge? And in the better coordination of those services by having the right insights, the right interventions on the right patients, are you having more impact? And then lastly, do these insights prompt you to look at the patients in a different way? Are you looking beyond the clinical conditions to consider the socioeconomic drivers that are really the drivers of risk and not just details about the patient that happen to be socioeconomic factors? I'm going to digress here for a second. Socioeconomic factors are extremely important. We know that they're drivers of risk. We know that they drive somewhere between 60 and 80% of health outcomes in a population of patients. And we've come to recognize that over the last decade, and especially in the last couple of years, more and more data are coming out, such that there is now not only a recognition of it, but also pressure from policy, from contractual obligations with payers and with Medicare, so that this is becoming, by necessity, a priority for everybody to not only understand, but to properly address. So as we look at some of the trends for readmissions, have socioeconomic factors in mind. Some of the trends, these are some of the data that we have from a source called Health Trust. And what do we conclude? Got a couple of takeaways here. The common conditions are still predominant. They're still driving and dominating the reasons for readmissions. When you look at COPD, when you look at heart failure and pneumonia, these populations are driving a lot of the penalties and challenges that we have around readmissions. Something else of interest, you can see there's a disparity between urban and rural areas. You can see there are disparities by region. The Midwest and the Southeast tend to be higher. And to understand it, you say, so what? Well, to understand what some of the drivers are there, it takes looking under the covers and both looking at what are the resources and processes in place that providers have, but also what are the socioeconomic drivers and trends and themes within a given region. So this is a very macro level. It's very high level, and there's not a lot you can conclude when you look at regions. as large as what we have here in the lower left corner, but it does prompt the right questions. And the socioeconomic determinants are important. So I'm going to dig a little bit deeper into that layer. What Jvion does is pulls socioeconomic data from a tremendous amount of different sources. We pull those together to understand patients holistically. And in addition to claims and billing, which is not socioeconomic, that's more the clinical nature. What the demographics are for a region, the food access is, U.S. Department of Agriculture data, housing and urban development data to understand housing access and transportation, air quality, all of these things, and along with this last bucket here, third-party purchase data, is all sorts of other insights we have, digital behavior and types of personas that we can both understand and then interpret what people are likely to be like and what they're likely to do. So we pull this information, and it starts with data, but the data are not enough. They're important but not sufficient, because it requires interpreting that data correctly in order to convert that into intelligence. So I'm going to illustrate this on the next slide here. Let's just take, for example, the question around housing stability. And we might intuitively say, well, let's put that as an index. And indexes are a big fad today, but they're built upon some wrong assumptions. So if I were to do an index for housing stability, and I said, the housing instability, they have housing instability. They've had a very short-term residence length, and that's bad. And long-term residence length, well, that's good. And if we put those things on the ends of the same spectrum or an index, that is where the fallacy occurs. Short residence length could actually be a good thing if this is an elderly person that was moving closer to their grandkids and they have support of the children and they're getting resources, and they have more social support network than they had before. Then suddenly this short-term residence length and having moved is not a bad thing at all. It's a good thing for that individual. And this highlights the point that when you just look at facts on an index scale, the interpretation is assuming that one end of that scale is bad and the other end is good. And it just isn't how it is in real life. So I want to emphasize, it takes intelligence to sort out socioeconomic data and to say, is this a risk factor? Is this driving harm for a patient? Or is it actually beneficial for a patient when intuitively we wouldn't think that? It could be bad, for example, on the flip side, if I couldn't afford my previous housing, if I've lost my social support, I'm stressed now living in a new neighborhood, I have to find a PCP, and all of the, not only network, but also usual access to resources that I've known and been familiar with are all gone, and I have to relearn those things. And that can be incredibly stressful. So short-term residence could be particularly good, or it could be particularly bad. We don't know. But what we do know, based on our insights around this, is that this one feature really interacts with other factors like renter status, their overall income level, what overall social support they have. And that those things together help us to understand whether moving is actually good or bad for the individual. So I want, the point I want you to take away from this slide is, while socioeconomic risk factors are important, it is not as simple as getting that data and putting it on a scale or an index than to say, well, this is bad because it's at this end of the scale, or this is good. Now we're going to dig into two studies here, and the results that we achieved were directly because of the insights we provide from the socioeconomic standpoint. So this all ties together. This first study was published in September of 2020 in Applied Clinical Informatics. And we looked at over 2,400 hospitalizations and the risk for readmission in that population of over 2,400 patients. And the absolute readmission risk reduction was 3%. It went from 11.4% to 8.1%. We assessed those patients for risk within the next 30 days after discharge. Some of the data that we included to understand risk in this population included, from a clinical standpoint, included the diagnostic codes, some vital signs, lab data, medications, claims, and then of course the socioeconomic information. Our recommendations from the core provided guidance around both the clinical and the socioeconomic levers that could be addressed for each patient, or the modifiable risk factors. So as I mentioned, in a pre and post intervention analysis, we had an absolute reduction of 3.3%. That translates to a relative reduction in readmissions of 25%. And the p-value for that, if anybody is interested, is less than 0.001. Now, this was also benchmarked against neighboring hospitals in the same geography. They had, at the same time, a 0.5% decrease in readmissions. So we call those the control hospitals. And in the control hospitals, a very modest decrease in readmissions also demonstrated statistical significance compared to the hospital where we were providing insights and they were acting on them. So this is the first study and analysis. One other thing that we looked at here, it's not in the slide, but one other point of analysis was if the insights were really helpful and the risk stratification was guiding correctly, then the highest risk patients would have had the greatest reduction in readmissions. That's intuitively what you would think. And in fact, that also was true. The relative reduction in readmissions in the highest risk group was approximately 28%. And in the medium risk group, it was about 25%. And I don't recall offhand on the low risk group, but those were the primary groups where attention and effort resources were applied, was to the high and medium risk groups. In our second case, this is a hospital in the Northeast. This is an internal analysis that was done for our customer Northwell, and we evaluated the impact of prescriptive analytics on the effectiveness of a transitions of care management program. So overall, you can see here, and we'll get into more detail in the next slide, the overall reduction over a 4-month period was from a baseline of approximately 12% to down between 7 and 8%, an absolute reduction in readmissions in that population. Now, we did a case-matched controlled analysis in this example here, and the cases were matched for both risk level as well as gender and age. And then cases were selected based on the cases where interventions were done were identified based upon the risk that was surfaced by Jvion. This has been validated by Northwell, and they've submitted and actually been accepted to present their results around this at HIMSS in August. So if you're interested in getting more details, be sure to attend HIMSS in the late summer season. One more level of detail here. And this is in the high risk group. Standard care, the readmission rate was 31%. And based upon the patients that were acted on that we identified as high risk, the comparative readmission rate was 24%. So again, a significant reduction of approximately 6% and 6.5% reduction there. And this is attributed again to identifying risk around the patients that otherwise wasn't recognized or appreciated, socioeconomic factors, as well as, of course, patients with clinical risk. Over the 4-month period, the reduction in readmissions resulted in cost savings, healthcare cost savings of over $450,000. And that was just in that 4-month period. Pause here just to give you a moment to digest. Now, lest anyone gets chest pain, I'm not going to go through every box on this slide, but this is a sample workflow of what we do with an implementation. And we have to understand workflows for a number of reasons. We need to understand who the roles are that are involved. Is it a case manager? Is it a clinical pharmacist? Is the hospitalist involved? So this is an example of a workflow and swim lane diagrams that we've put together. And this also helps to standardize and make consistent the process by which patients are evaluated, how our insights are used. It allows better tracking for whether procedures are followed. It also, when this is completed and it's followed, it helps to inform ultimately what we all desire is electronic health record integration, and mapping that out in detail. If anybody's done EHR implementations, mapping that in detail is required in order to make sure that the build and integration is correct, or you can have a misfire in the build, and then you're having frustrated clinicians and you're having to backtrack on some of the work that was done and redo it. So this is part of our, what I would consider a best practice in terms of documenting and implementing both the insights that we have, how it's operationalized, and also in preparing for electronic health record integration. Just to put a cap on this, we've been involved in healthcare for over a decade. We've focused on the clinical, prescriptive insights for more than 5 years, in particular, incorporating socioeconomic determinants into those insights. We're one of the market leaders in this space, and we've seen a tremendous amount of impact. And as I shared the studies there, we are now involved with publishing those results, because getting those published is important to get the word out in a legitimate way that this is impactful. I will come out of presentation mode now and be happy to take any questions. I'm looking at the chat and I'm not sure if I'm seeing any questions in the chat. And I don't know if I'm going to ask Jay here if the audience is muted, if they're welcome to type in questions, or even if there's a way we can take people off mute.
If there's anyone that has questions, feel free to submit those now.
We appreciate your time today. We would be happy to talk with you further about how you can leverage with a speed to value approach clinical prescriptive insights to better manage your at-risk populations, both for readmissions as well as for any number of other use cases. And we'd appreciate the opportunity to follow up with you. I do have a comment here that people do need to use the Q&A. Chat's disabled. And I've got also a question here. What EMRs have we integrated into to date? And the short answer is all the major ones, including Epic, Cerner, Allscripts. We've even done Horizon, McKesson Horizon, Paragon, and Meditech, as well as some non-traditional EHRs. They're not even EHRs, but other non-traditional workflow engines, even CRMs as appropriate. So we have the ability to integrate into any system. The more important question is, do we do it effectively into the workflow of the clinicians? And that is always a priority for us. Keep in mind, these are insights. And so we want to provide insight at the right time, using the 5 rights, the right time to the right individual, for the right patient with the right information. There's a question, and Jay, I'm not sure the answer here. Will we be able to distribute a copy of the slides? And we can circle back with the audience to see if we can provide a copy of the slides, or if you reach out to us or we connect with you, and we can perhaps in a follow-up conversation, then provide the slides. It's great. I got a couple of questions coming in now. The question here is, what pre-work has to be done with the HR data to use the algorithms? And so there are two questions here. That's the first one. From a technology standpoint, data flow standpoint, we get very standard data sets from the EHR. I mentioned some of the data sources in the first study. It includes a data set that is generally available in a standard HL7 feed. So orders, labs, medications, ADT data, claims data, all of these things don't require work on the part of the health system team to package it in a particular way or normalize the data or have it coming from a data warehouse. It can be just a straight up HL7 feed, and we can take it from there. On our side, there's more complex data science than having the embedded in the question is to use this for algorithms. And I want to highlight what we use in the data science side of this inside the Jvion core before we send the insights back is far more than a single algorithm or even a package of algorithms to identify patients who are at risk. It's a more sophisticated data science approach we'd be happy to share with you in detail on a follow-up call. Then there's another part two of the question, the NLP aspect of the solution. And at this point, we have found in natural language processing, and I intuitively thought this even 5 years ago, if we could just get the clinician notes and do NLP on that, then we would all be a lot smarter. What we find is that unfortunately, the clinician notes are not as helpful as we thought they would be, and we're finding tremendous impact and insights based upon the combination of the socioeconomic data that we purchase and combine that with clinical data that we get that is more discrete already, and then with mapping it to endpoints, target endpoints that we have based on claims data and patient stories, essentially clinical stories of over 30 million patients in our data universe. So when you put all that together, getting NLP functioning on clinician notes doesn't add as much lift when we looked at it as we thought that it would. So we typically don't use NLP, but we have the capabilities. Another question here, isn't clinical data alone enough to help us tackle readmissions? And that's kind of the definition of insanity. We recognize patients are at risk because of certain clinical conditions, and you take a LACE score, for example, it's a very raw score built all off of clinical features. Let's say you add another dozen features and you build a predictive model, and those are all clinical. We know that the drivers of risk in a harm event called readmission is heavily contributed to by socioeconomic factors. So that's the data that's well established there. But again, I go back to having socioeconomic data. So if I let's say I have an EHR that says, well, give me your socioeconomic data survey, and we'll put that in, and then we'll spit out a risk factor based upon the data that you collected. It's heavily dependent then upon patients giving full and complete answers. It's heavily dependent upon assumptions that data produces intelligence, and I've already demonstrated in some of the earlier slides, having that data does not produce intelligence. It's incorrect. It has incorrect assumptions built into it. So clinical data alone we know is not enough, and neither is socioeconomic data alone. It's data that is correctly interpreted. And I have another request for the slides, and so I will definitely follow up with folks and see if we can provide those for you. And feel free to email us as well. We appreciate the chance to speak with you today. I can scroll down. I have one more question here. Question around APIs, and we are actively. It's part of our roadmap for the next few months here. I don't have an exact date, but we're getting APIs in place and mapping to the FHIR standard so that we will be able to be more nimble in setting up interfaces and having it improve the user interface for clinicians as they use this within their workflow. Great set of questions. Appreciate everybody's participation. And on that note, we'll close for today. Thank you for your time and look forward to following up with you, any questions and sharing more information with you.